So a lot of times these kids have, other co-occurring things that we need to be paying attention to, or we're not going to get, can they functionally improve? Sure. But are we going to get the best bang for our buck, the best result without involving kind of this kind of bigger picture, more holistic thing? No, probably not.
If you had to tell every parent before they had a kid, before they had a baby, even before the first 3 years, what's 3 things of advice you'd give all parents? Hi, Christina. Welcome to the Authentic SLP. Thanks for being here.
Thank you for having me.
So just starting off, tell us a little about your journey and your story and who you are and what you do.
Sure. So I have been a speech pathologist for 18 years, 18 years now, and a lactation counselor, about 10. So I can't believe that, but yeah, so I started out, I went to the hospital straight out of grad school. I always wanted medically based speech pathology. So, really got a lot of experience in that, and specifically to feeding and swallowing, straight out of grad school. Really, we do our clinical fellowship year, after grad school. And so that was spent primarily doing an intensive feeding program and swallow studies at our local children's hospital. So I did that for about a year, and then I moved to North Carolina and I did inpatient pediatrics, and I was in the NICU and PICU pediatric ICU there for about a year and a half. And then actually came back to Florida, back to the same hospital. I had a couple patients actually that had just passed away in a row. So it was it was a rough time, emotionally. So I wanted a break. So I came back down to Florida, and was back at the Children's Hospital for another, that was 2010. And I stayed in the hospital system, in 2 different hospitals for the next about 8 years, almost 8 years. Just kind of then I started to build my practice up on the side, and really wanted to be able to get out in the community and provide a different kind of care, a different kind of therapy. So left the hospital full time in February of 18 and have had my own practice ever since.
Yes, that sounds good. Hey, question. So I get this all the time as a clinic owner, is all the speech therapists who want to be in the NICU or the hospital. So you've been there. Do you know why, or I can kind of understand why the draw is to work in that setting, but why do so many people want to? And then what are the pros and cons? And not either is bad, but just kind of pros and cons of working private compared to hospitals. So if someone's listening to this and they're deciding where to go, what do you say?
So I loved working in the hospitals because I really like challenging, complicated, difficult cases and intense cases, and I really like problems that I can fix. And those I want to say, I don't know if tend to be is the right word, but they, you can find shorter term fixes there where, okay, here's the problem, here's the solution. Unless obviously you have kids there in the NICU and stuff that are going to have chronic conditions. Obviously that's different. But when I do swallow studies and things like that, okay, there's a swallow safety problem. Here's the strategies I can use to fix it. I can find a fix for it. So that drew me in. I also think obviously there's an allure. Oh, get to work with brand new babies. I get to just feed babies for a living. There's a misconception. I think that's basically all it is. And not as much, not all it is, but that not without the recognition of kind of how intense it is and just the dynamics of nursing and doctors and getting the team collaboration, because some places are more receptive to that than others. So I think it has a reputation for being kind of the badass place to be, and because it's so hard to get in, and no one wants to train you, but you can't get trained until someone will take a chance on you. And so I think that a lot of it is clout's not the right status. Okay, I made it. I have this special training, because it's kind of once you're in there, that's probably the most intense, most kind of precarious health situation, just because those babies are so tiny. So once you're in there, it's oh, okay, now I can, take my skills and I can really go anywhere if people ever want to leave. So I think it's more of it's a status thing. And I also think, and there's the feeding babies aspect of it. But it's not easy. You don't necessarily get, I really appreciate now more than ever kind of the relationships that we develop, not just with the patients, but with their families in particular. And so, because of the high stress situation and just the sheer number of people those parents are dealing with on a day-to-day basis, inpatient, You don't always necessarily get to develop. You can, don't get me wrong, I'm not poo-pooing. I know plenty of NICU therapists who have wonderful relationships with their patients' families, but that could be a little more challenging. It could certainly be emotionally challenging. Like I said, I had 3 patients that passed away. It happened to be right before Christmas, right in a row, which was when I left. I just needed a break. And it's not for the faint of heart, and or depending on what you're doing in the hospital, especially in pediatrics, and it's not easy. So like, I mean, if someone wants to do it, like, you have to be prepared to like be on your A game, and like, it's not a place where you can mess up. I mean, not to be whatever.
That's why it's hard to get in. Yeah, because you don't. I mean, do
Very
you want
little
that
room for
stress
error.
on you?
Exactly. So, I loved it, but you have to work fast. You have to work hard, and you can't. I think, understandably, the staff there, the nurses especially, are very protective of, their babies. And so kind of be respectful of your role, but you got to know what you're doing too. Like, if you don't know what you're doing, you're not going to be making any friends in there. So like, I think it can be intense. It can be an intense environment. If you're good at what you do, and especially, you can get parents involved in stuff, it can be incredibly rewarding. But I also had plenty of abuse cases too, where you're standing there doing parent education, talking to the very people who are the cause of their child being in there, basically in a vegetative state. So I think it's cool.
Yeah.
It's cool, right? And it can be intense, and in that way, in a good way, and keep you on your toes and make you good at what you do. But you have to be proactive, and you have to be fast, and fast in an active way, and okay with that.
So it's a high stress environment, and you've got to be good at it, because you could really hurt.
And I think, as you know, being in
aren't.
the medical field, in not just speech pathology, this is for anything, but just with the state of insurance and everything else nowadays, I think it's challenging to be in a hospital setting a lot of times, because there's a lot of pressure from above on productivity and on, how many patients you can see, et cetera, et cetera. So I think you have to be prepared for that especially in a hospital setting like that, not just inpatient, but you're going to be dealing with a lot more bureaucracy in that sense.
Yeah, absolutely. So speaking of that, what inspired you to start Madden Therapy Solutions?
I would say what started was I was in one of the children's hospitals down here in Florida, in the Tampa area, and I loved it for many years.
There's 2.
Yeah, there's 2. I've worked at both. And the one that I started at and came back to, it gave me a lot of really good experience and many years there. I spent many years there, but I just would say that over the years, over my tenure there, I saw some of the cultural shifts that took place in merging with a larger health system, medical health system. And I saw it go from a place where really I moved down here when I knew no one. And so I made all my friends there. And that was like where, so it was it felt very patient first. It felt very, much like a community. And then I would say the years that we transitioned and merged with this other health system, I definitely, and changes occurred down the pipeline with insurance and everything else. I saw a lot of shifts in not just my quality of life as a therapist, which certainly was affected, but also in the quality of care I could provide patients. So I was tired of that, and I just ethically, it didn't sit right with me. We all got into this to be in a helping profession, and I felt like I wasn't making the impact that I wanted to make. So I went to the other children's hospital for about 1.5 years, to see if it was the same everywhere. I wasn't really ready to cut the cord with being affiliated with the hospital yet. And if it was the same kind of pressure cooker everywhere, or if it was a little bit better. And so I got some of my groove back there. I was thinking about leaving this field for a while. So I got back into that mindset. And started building my own practice on the side. And I really just intended for it to be just me forever. I was like, maybe eventually I'll hire one other person, but my intention was really just to go out so I could work for myself and control the kind of care that I could provide, and get out into the community and provide kind of real life functional therapy rather than just my perfect controlled office. And then so that was really the intention for doing it, was for my own quality of life and for the quality of care I could give these patients and their families, and not be bound by red tape and productivity and bureaucracy and all that. And it was received. And
part of that is that I know one thing is, like, you don't, at your clinic now, you don't, in your practice, you don't take insurance and everything. And I think you do that for a reason.
Very much
so that you can be out of that red
Yep.
tape and provide the care that you
Right.
want.
Which
Correct?
exactly, which has its pros and cons as well, for sure. But that has been a very intentional decision on my part, not to get involved in that, which I talk to parents about a lot because I want, at the end of the day, and I'm sure we'll go into this later, but at the end of the day, I want the one deciding on the care plan for their child to be me and the parent, and not a non-clinical or not person who doesn't know us, making decisions. If you get 20 visits a year, you get this.
Absolutely, absolutely. Actually, we're going backwards. We're trying to take less.
I get it.
You were right at the
I get
beginning.
it.
It's so hard to go
So
backwards.
hard.
It's so hard, but
No, I
yeah.
took this and now I don't. Like, no, I have developed and amassed, and I'm sure you're familiar with a lot of these, but a lot of resources locally and nationally now between different scholarships that are out there and different resources and grants and stuff for people. So I do try to help educate and navigate people so that, because make no mistake, not every family of ours is wealthy by any stretch. So it's a question of prioritizing, what matters to your family. Not that by any means, if you need to go through insurance, you don't, but I'm just saying, like, some people are like, no, this is what I'm going to allocate this budget for, or whatever. So prioritizing that, and then also, seeing, like, I believe firmly in my heart, our therapists are just phenomenal therapists. So they're getting excellent quality care, and I believe in that. And so as long as we can stay true to that, that's been very intentional for me, that I didn't want to get wrapped up in I didn't want to get wrapped up in putting my energy toward insurance when I could put that energy toward the patients.
Right. Well, once I realized I was paying $10,000 a month for a billing company just to bill Medicaid, I was like,
Probably in the red just from that.
yes, exactly. It's crazy. I was like, wait, I would rather lose $4,000, $5,000 from Medicaid and be. So that's kind of where my brain is. But yeah, it's crazy what we do just to help families when we could be looking at scholarships and other nonprofits to help cover therapy. Because one thing, and I'm sure we'll get here, is that, and I want parents to understand that quality over quantity, that if you get quality, what's right for your child at a young age, they don't have to be in therapy for 7 years. So the cost is less because you're getting quality and not as long.
Yeah.
So I think that's a good trade-off.
I'm not in this for, not that I wouldn't be if they needed it, don't get me wrong. But, I'm sure the term, we would, say this in the hospital, you had your patients who were like lifers and they just had these chronic conditions, so they've been in therapy forever. Now, don't get me wrong, I've had patients I've had for many years. But by and large, if I have a patient that has a condition that can get better a lot faster, I'm seeing, and again, I don't want to generalize, but at least in what I'm seeing, so much more buy-in, so much more parent involvement. They're not just dropping their kid off for us to fix them. It's like they're involved and they're doing that carryover, because who wants to private pay for their kid to be in therapy for years? No. So, like,
I mean, I'm sure there's some people, but
some people will do it, don't get me wrong, but in an ideal world, now I've got these parents who are saying, now here's what you're really going to work on this week, because wouldn't you rather private pay me for a few months than...
Exactly. And I think that's huge. And just understanding when parents are weighing pros and cons of paying sometimes higher for a service, that's just something to take in consideration, and finding the right therapist, right?
Sure.
So speaking of that, what are some of the things that you guys in your clinic, like, where do you specialize? Where are you located? What kind of services do you provide?
For sure. So our main office is in St. Petersburg, North St. Pete, right off the highway. It's actually really centrally located, but we also do in-home and in-school community-based around most of Tampa Bay, honestly, pretty much all of Pinellas and Hillsborough County. I am looking at expanding into additional locations in the near future, in terms of having a brick and mortar option for people in additional locations. But right now, we do office in St. Pete and then home-based all around Pinellas and Hillsborough County, so over most of Tampa Bay. We started out just as speech, feeding, and lactation, because those are the things I did. And so we still do that. We've now since added pediatric occupational therapy, myofunctional therapy, pediatric sleep consulting, and some pediatric work with a dietitian. So like holistic nutrition, and we just added tutoring. So I'm very excited about that. Tutoring just started with us. I'm pumped about that. And I'm trying to add pediatric physical therapy. So if I can find that unicorn, if I can find the right fit, then that's a goal of mine, but we don't have it yet. So right now we're speech.
If staffing was an issue.
Which it always is. I mean, that's the name of the game these days. I mean, I've been hiring for 6 new positions. I just hired for 4. So I've had those other 2 out for months. So staffing's always an issue. Speech feeding, I would say feeding, lactation, and myofunctional therapy and especially in the last few years, has always been like our niche
Yeah.
specialty. When I first started this in 18, almost no one outside the hospital system was doing feeding therapy. Now there's a lot more, not a lot, but there's more like one-offs, kind of single practitioner practices. I don't want to air quote that. Single practitioner practices that, do feeding, which is great, and that's fine. So it's become a little easier to find. But so feeding, I would say speech and feeding and lactation and myofunctional has been our specialty for a long time, as well as obviously the speech therapy. And then have now gotten a lot more heavily involved, a lot more cases of OT, which has been really fun, honestly, doing the case collaboration and the co-treats and everything else, just in terms of seeing that progress kind of exponentially more when we can target all things at once, which has been really cool.
Yeah, OTs for sure are a missing piece to a lot of our kids, I think, So almost like all speech, if you, in my opinion, is almost like always you need an OT eval too. In most cases, there's very few that I wouldn't say it wouldn't be a bad idea to do OT as well.
Nothing happens in a
So,
silo, right? So a lot of times these kids have, other co-occurring things that we need to be paying attention to, or we're not going to get, can they functionally improve? Sure. But are we going to get the best bang for our buck, the best result without involving kind of this kind of bigger picture, more holistic thing? No, probably not.
absolutely. I'm seeing the same thing. So that's awesome that you guys have added all those services. Because I mean, that's hard. It's a lot on your plate, but
And
also
it's,
it's so
it's a lot of
needed.
different
It's a vital
personalities
piece.
then when you get into other disciplines. I mean, I feel like most speech pathologists are very similar personality wise. And so it's been a learning curve, even just as a business owner, like just seeing how to manage different specialties and people. And it's been fun, but it's,
Oh, we are reading emotional intelligence as a clinic.
I love that.
Right now.
I give a personality assessment to every potential employee before I hire them, just because, like I always say, okay, this is like my New York coming out right now. So like I always say this line when I'm interviewing anybody. It's like, okay, especially if you're speech, I can teach you clinical skill. I can teach you to do speech therapy. I can teach you to give good feeding therapy. I can teach you all those things. I can't teach you not to be an a-hole, and I can't teach you to get along with other people. So like I don't want drama in my office. I want a close-knit group of people, especially because this is such a female-dominated field a lot of times, and I don't have time for that. Who wants drama in their workplace? No. So I do give a personality, and it's not like a pass-fail. I always say to everyone, I'm like, this is no right or wrong. It's just so it tells me how to communicate with you best, if you come on, and for the team to communicate with you. So I think something like that, like reading up on emotional intelligence, and whether it's personality assessments, whatever it is, for me, just in terms of the not being a toxic workplace, being a healthy workplace that people want to be and are happy and want to stay and work hard, because as you and I know, those other things are the things that burn you out and make you want to leave. And I have no interest in being a revolving door for my therapist. I love my therapist. I feel incredibly blessed to have them. So I'll do whatever I can do to make sure we're setting us up for success in that sense, as a clinic, as a team, etc.
Absolutely. So if you're in grad school and you're thinking about being a speech therapist, one thing that you should really work on is your emotional
I think
intelligence.
so.
Really, before you get any job, because it's only you can be the best clinician, but if you can't even relate to your parents, right? If you don't know how to deal with difficult people, you can have clinicians that can really hurt your reputation just because they're of what they
Hire a couple
say.
for that reason, 1,000%, and nice people. It's just, I think, and as you know, when you're working with children, period, and then you're working with children that have some kind of quote unquote problem, right? Whether it's some kind of diagnosis, whether it's an accident, a tragic accident that's happened, whether it's your child is
Mhm.
behind. And to me, it's all relative. So I get a lot of parents, and I'm sure you do too, that'll come in and go, well, I know it could be worse, or I know I saw this kid in the waiting room have the X, Y, and Z. And I'm always like, that doesn't make your experience any less valid. Like we're all going through stuff,
Right.
on different levels. And so it's really important to me to have a staff that is super sensitive and empathetic to families in that sense. Like, I mean, I'll use feeding as an example just because it's my baby and it's so near and dear to my heart. But like, just from a feeding standpoint, if you look at, if you think about all the social things we do around food, Thanksgiving, going out to eat, all these social positive things, a mom pregnant, dreaming of nursing her baby or bottle feeding her baby. I don't care what it is. That's your bonding time, right, with your baby. And so when you have a baby who won't eat, this isn't a, oh, let me just grin and bear it and get through this one dose of medicine. This is something they're facing all day, every day. And so it's torture. And they essentially get robbed of that experience, this bonding experience that they've been thinking of or dreaming of for all these months. And so I think feeding in particular, like, you have to be so sensitive and so aware of your words, so emotionally intelligent to talk to these parents, because they are going through it. And like, they need a teammate. They don't need a white coat talking at them. They need someone who really genuinely cares and is in it with them. And so I need a team that feels this. I can't teach you how to be kind to a parent who's going through it, you know? So like,
right. Absolutely. That's good advice to give to people going in the field, and then also to parents too, because also I think it's good for parents to know, because if they come to you and they're not happy with a therapist, would you like them to talk to you about
1000%.
it? If you feel like, exactly.
1000%.
So many parents are afraid to say something, but like, if it's not saying that that therapist is even a bad therapist, that just might not be a good fit for you. So it's always better to speak up. Don't just stay in therapy because you feel bad for the therapist. Please don't.
I am not the best fit for everyone. So like, I mean, as we all know, like, I also think as a therapist, like, you can't come into this with any ego, which I think is very hard when you're young, because you're insecure too, because of what you don't know. So that's hard if some parent, you're not their best fit, to not take that personally. But at the same time, in 18 years of doing this, I'm not everyone's best fit either, you know? So like, I would always rather a parent tell me than either suffer in silence and their kid's not getting the connection or the help that the parent feels would be in their best interest, or they leave my practice because therapy wasn't working or therapy wasn't a good fit. I would much rather them talk to me so I can find them. Let's give a try of somebody else, see who is a good fit. And I mean, like I said, I love my therapists. I think they're all phenomenal therapists. So it's not a reflection on them. It's just not everybody's a good fit. So like, I think maybe in larger health systems, maybe it's a little more difficult because you don't have the personal connection. But like, when I think about you, or I think about me, or someone who has a small business, right, that's like local, no one's a number to us. So like, I know these families, I see these names coming across my desk every day, and I, have relationships with them. I would always rather them talk to me. Someone. I used to do every initial evaluation. We got too big for me to continue doing that. But it was because I wanted parents to have a face of like, you ever have an issue, you've met me now. We have a connection. Like, here's my cell. We can talk if there's ever a problem. I've never had that happen. But I do reach out with parents and check in from time to time. Like, hey, just want to see how it's going, because I want that feedback.
Awesome. Yeah. It's so important, because I've seen families that suffer in silence or just leave. And like, you would have liked to know, because we understand that. Speaking of that, is there something that you guys don't focus on? Like, you're like, this is not kind of what's best for our clinic. Or you're kind of like, at this point, you have enough that you feel pretty good with everything.
I'm definitely not good with everything, right? No man is an island. So I think it's really important to have a solid team of people you can refer to, right? Like, I have my recommended provider referral list that is admittedly not easy to get on, because I want to talk to these people and I want to essentially vet them. And because if I'm attaching my name to it, if I'm saying, hey, call Nicole, call her practice, call Bayside, because I know they're really good at this, and that's not really, prompt. I'm going to take prompt, for example, for like kids with severe apraxia. Like, I have nothing to do with prompt. Apraxia is by far not my wheelhouse. So like, one of my therapists in particular is strong on that. But in particular, if she's not free, or if it's even, let's say, a more complicated kid or a more severe kid that I think needs more help, that's something I'm going to refer out. So like, I have a list. So I always think it's good to have a list of providers that for certain things, we can't all be all things to all people. So like, I know my own limitations. Again, this comes down to, don't let your ego get in the way of like, would it be awesome to charge for every service under the sun? Yeah, of course. Is that ethical of me? No. Yeah. I never want to be a person who a parent is saying, well, of course they're going to recommend this because they do that. So it's in their interest to recommend that therapy because you know for it. I would much rather give you some suggestions if it's warranted, give you suggestions on the phone and go, try this and call me back if it's not working. Like, I never want to be just, hey, I'm blanketly recommending the same stuff for everybody because that's going to behoove me from a business perspective. No, that's a short-sighted thing. So
yeah,
I want parents.
Well, like for us, like we don't do ABA, we don't have our DIR. Like, so like when it comes to kids with a lot of behaviors, that's just something that our clinic, we refer out, because That's just not, we know that we're not going to provide your child, not that all children have behaviors, but they need more than just maybe just speech, because we only have one OT. So we're going to refer out for those kids. Is that something that you guys could take on? Do you have that? Or
And I
is
actually
that
just
something
hired a
you would
new
refer out
OT
to?
who's amazing. So we do have I just hired another OT who's
Awesome.
amazing. So
I love
we have
OTs.
3 now. So I'm happy about that. We have 8 speech therapists and 3 OTs now. I'd like to grow that. I'd like to get PT. Sorry, so I digress from your question. So yes, so like something like severe apraxia, we'll take on OT, obviously. Any PT case, I don't have a PT. So if it's an older kid with PT
Okay.
needs, I'm going to refer that out. Because
Okay.
of our connection with feeding, we work a lot with kids with ARFID, avoidant restrictive food intake disorder, which if it's a parent listening to this and your kiddo has been diagnosed with that, you'll know what it is. Otherwise, you probably won't. But we see kids with that a lot. A lot of clinics don't deal with that. But there is usually there is a psychological component to that. So if I'm going to see a kid or one of my team is going to see a kiddo with ARFID, usually we'll pair up with a local psychology practice or therapy practice as well. So we can
Yes.
tackle it from both sides and get the best
Absolutely.
result. Same thing. That was one of them. Oh, ABA, just like you guys. Like, we don't do ABA. That's not our model. Again, being private pay, like a lot of those ABAs, especially if they're with them full time, first of all, it's not feasible from a financial standpoint. B, it's just not our model. Like, I'm just so customized and so, not that ABA can't be, but I'm so particular about child to child, and like, it's just not our model. I'm not in it for a full time. Your kid just is with me full time, and the parent's not necessarily as involved. I want the parent involved. I want them there for your finite period of sessions, and you working on that for carryover at home, not me doing that job 24/7 essentially. And I think there's wonderful ABAs out there, and if I think a kid needs it, or if they have, there's some not so good and there's some that are great. Like, same thing, like any other specialty. To get on my ABA list, I know the owner and I am confident in how you do therapy. And that's hard because people don't understand. You do, but a lot of people don't understand when it comes to things like RBTs, registered behavior checks. The BCBA, the head therapist, is not the one doing the therapy most of the time. They'll do the evaluation, and there can be, again, I never want to overgeneralize, but there can be a lot of turnover with RBTs. So how one does it may be very different from how the next one who replaces them does it. So we tend to develop relationships on an individual basis, and I really appreciate when it's an ABA company that will allow co-treats or allow their therapist, whether it's to come into our office or us to go to them while they're having one of their ABA sessions, because if they're the ones that are with them a lot of the time, then I can train them in what's safe for them to do to carry over at home, because that's another caregiver for the child. So then I'd like to use that to my advantage, but that's not something I have an interest, at least right now, in picking up ourselves.
Right. And every family, like what I'm learning is like, and I'm sure with emotional intelligence, and you're learning too, is that like every family wants and needs different things, and my job isn't to judge them. So I just try, if that's what they're interested in, then I want to provide the best, a place for that. So yeah, ABA wouldn't be us. I think the DIR floor time model is pretty cool. And I know that a lot of OTs do some similar things too. So that's awesome that you provide that.
Yeah, I
Because
love some of the
OTs are
physical stuff. That's probably why I want to involve PT too, because one of my OTs in particular, we always joke she should have been a PT, because she's taken a lot of the movement courses and the postural stability and things like that. So that's something I'm interested in going toward, especially from like intensive program type standpoint, just because there's not a lot out there for those kiddos. And so
There's not. Do you do intensive feeding?
we can do intensive feeding. I have done a few of them. I haven't advertised it big, just because, again, not coming from an insurance standpoint, it can be a little tricky from a staffing perspective. So if I pushed it hard and marketed it, then I could probably come up with a wait list, et cetera, and make that work. But what I like about it is not dealing with insurance. I've been able, with those kids that we've done intensive programs with, I've been able to really customize those programs. So like, I used to run the one at All Children's, and it's been really interesting looking back on our program. We took insurance, obviously, was 4 weeks, 5 days a week, 4 feeding sessions a day, except for on Fridays. It was 3 feeding sessions, 1 OT session a day. And so it was this prescribed program. Fine. We had a lot of great results. But when I think about myself as a therapist and how I did the therapy, it's different than I would do it today. Because I think when you have to get it covered and you have to prove to insurance, we've improved by X% by the end of this month. It's a naturally slippery slope to want to be like, we can get in one more bite, or we can get this, versus child-led or more child-led. And what are they really ready for. And I'll give you a really quick example. Is I had a 8-year-old, seven, who had come in, and he had PTSD from prolonged hospitalizations. He had had a liver transplant and a kidney transplant, and prolonged hospitalizations. He had PTSD from that. And mom wanted to get him in for an intensive program. Like I said, he was 7, cognitively delayed. So he's probably about 3 years old, cognitively, developmentally. But he could understand. So cognitively, he could participate in a program. But he had no feeding tube. All his nutrition was via Pediasure in a bottle, and he was 7. So mom wanted him off the bottle, and then she wanted him. He loved the taste of solids, but he couldn't chew anything. So he would panic when they got in their mouth. Like he could lick things, but that was it. So we were working on him actually trying to ingest solids. And so mom had originally gone with a different program than us because they had maybe psych in-house. I can't remember what it was, but maybe psych in-house. And she went with them. No, it wouldn't have been psych. Anyway, it doesn't matter. She had somebody else in-house that she went with that program. And it was supposed to be 10 to 12 weeks. They didn't give an exact time, but it was partially covered by insurance. But I want to say mom paid like 15 or 20 grand out of pocket for it, for this 10 weeks and prepaid in advance, and ended up having this terrible experience that the kiddo was, which they promised her wouldn't happen. The kiddo was force fed. I don't want to scare parents. This will not happen at every program. This is just this story. But mom had ad nauseum asked people, are you sure there's no force feeding? There's no force feeding. There's no force feeding. I know this because she and I had several hour-long conversations before we ever took him as a patient. So like she and I know each other well. And I was talking to her for probably a year before he started with us. Anyway, he got so stressed in this other program, they wouldn't let mom back, so mom could never observe. She never knew what they were doing. He would come out with food that had clearly smeared on his face, so he had been forced to some extent. And he had this underlying autoimmune condition that ended up flaring up because he was so stressed, and he went back to the hospital for a couple months. Anyway, he came to us eventually, and I was really happy he did because I was able to talk to mom and say, okay, he needs a lot of oral motor work. It's not appropriate for him to come months at a time. He's 7 years old. He's very traumatized by all these hospitalizations and things. I don't want him. They were coming from out of town, so he was going to be staying with mom in an Airbnb anyway, and they were going to be leaving the rest of their family in their hometown. So I was like, I don't think months at a time is appropriate. I want to do 2-3 weeks at a time, and I want to do very low pressure, positive experiences. Then we're going to send you home with a home program. You're going to practice it a few months, and when he's made some progress, we're going to bring you back and do it in these short stints. What I loved about that was that his case ended up being very sad. He got sicker and sicker. He passed away. Nothing to do with his therapy. It was just his situation. But in the time, he got to actually participate in these things in a very pleasant way. And mom got to actually have fun experiences with him with food and things like that. And so it's really, to me, it makes it much harder to develop a program because we don't have this very prescribed protocol, because I don't buy into that for the most part. But I think it makes for better therapy in this particular case, because then you can really customize it to what's appropriate for the child, what's appropriate for the family and their goals, and things like that. So yes, so we can absolutely accommodate intensive feeding. And then my goal is to be able to do that sort of thing for other places as well, because as well as I do, everywhere has huge wait lists, and I want to get these therapy now.
Yeah, and I think interesting that you said that was a really good point about when you're taking insurance is having to prove things like it's a slippery slope. I didn't even think about that. Also, I know one of my friends, Alicia from Family First, she's starting a nonprofit to fund intensive feeding programs for anywhere.
That's amazing.
So I'll make you guys get together, because I think that would be great. Because I think it's not just intensive feeding, like this is what we're going to do. It's different for every child.
Every child's different. They didn't have the same journey to get there.
Exactly.
So like they're not going to have the same journey back. And they all have, I've got one kid that might be only eat food that's white. That was one of my patients. Only ate food that was white. And then I've got another kid that only eats carbs or only drinks, doesn't do any textures at all. So like the situations you see are so different. How could my treatment be the same?
Mm-hmm. Right, absolutely. So that's really down the key to everything. It's finding the right program, the right school, the right placement for your child, because your child's so unique. It's putting them in the right place to make them successful. Because you can't just make every kid the same.
And like you said, as far as talking to the owner, if you don't feel like it's the right fit, therapist or practice, if you feel like there's a better fit and like let's say you've tried some of my therapists, I'd be shocked, this has never happened, but like, and you're just like, I'm not jiving with your practice, I want to be somewhere else. Okay, I'm going to go probably find you other resources that are other places. I'd rather your kid get help. I don't need to hoard everybody. I'd rather your kid get the appropriate help and someone that you connect with and vibe with and buy into than just having to keep those kids for myself.
Absolutely. I always take it to like, in the Miracle on 34th Street, you know what I'm talking about? When he's like, if we don't have it, I'll send you to the other places because, then it's true. If we don't have what you need and your child needs,
I'll find someone who does.
All clinicians are going to help you find the right place because we all care about your children.
Then my hope is you have someone that's going to find you the right place. I mean, we had a mom that called a while ago. She lives an hour and a half away, and they're not a wealthy family. And so she was really looking for insurance, and she was looking for close. And I was like, oh, you're out of our service area. I'm so sorry, but I'm going to go help you find someone else. And I went, you and I are on a lot of the same servers and Facebook groups and everything else. And I went trying to find a closer therapist for her. And I got like 3 names, and I sent it to her. And she called me back like a week later and was like, I've left messages for those 3 places. No one ever called me back, but you really were so kind to try and find a different place for us to go. We're going to come to you anyway. And they came twice a week. They drove an hour and a half each way to our office just so they could so I believe that stuff comes back to you. Like, I didn't need to keep that kid. That wasn't why I did it. I didn't intend to keep that kid, but like, just do right by people. Just find them the best therapist for them. And if they can't find one, then they'll come back to you. And that's great. And then hopefully everybody wins.
And so again, if you're a speech therapist listening to this, please keep that in mind because
if they're not,
it's good to, because then it's bad for both the parent, the child, and you. Like, who wants to be treating a child that's not right, that you're not helping?
I've had parents that'll be like, well, I really want you. And it'll be a certain kind of, right? My name's on the door. They're like, well, this is...
Yeah, I know. I get that too.
It doesn't happen as much anymore, but you being the owner too, you get the same thing. Well, I really want you. And I do so much managing. I really don't see it. The only patients I have left are a couple of my like OG. I've had them for years. I'm never letting them go. And other kids that I had for years that I had to give up. I just didn't have the time. So some of my therapists, after extensive training, took those kids over. And I just think like, I would much rather people get the help they want. Like, they get the help they need. I'll tell you right now, I've had parents that'll call me and go, I really want you. And they'll come back and go, you don't want me. I'll find you. I'll give you. I'll give you. I'll either match you with one of my therapists that I think is the best fit, or I'm going to refer you out. But trust me when I tell you don't want me. If it's a reading kid, I'm not touching that kid.
I have a list of people really great people that I can
It's like I finally hired one of, Lauren, I hired one of my friends that now works for me and she's a reading therapist. I'm like, well, thank God, because I can't touch that. So like, I try to hire around things I can't do, but like also, I also recognize, again, we can't be all things to all people. We don't have every specialty under the sun. Look at fluency. A lot of people that don't do stuttering. So like, then I'll find people that do.
Yep. Yeah, I know. There's so many theories I have about all these things, but we'll talk about that later. So right now, what's something that you're really passionate about? You're just like, this has come out and I feel really passionate about this. Anything?
I mean, obviously feeding therapy in general is like that's my baby. That's been my baby for 18 years. So like when I lecture on this a lot now. So I think that's probably why I'm more pumped up on it now is that people that have asked me to do continuing education and things like that around feeding. Because I think, we're basically taught these schools of thought as far as feeding therapies. There's like sensory-based behavior feeding, sensory-based feeding therapy, like very child-led, but a lot less. This is my very kind of basic version of these, but a lot less pressure, a lot more child-centered, but progress can take a lot longer. So I find long-term outcomes and associations with food tend to be great, but like when you're dealing with certain situations, it takes a year to only eat 1 or 2 new foods. I don't know about you, I ain't got that kind of time. And then I could if I needed to, and then you've got straight behavior feeding therapy, which is much more adult based. And I know I'm saying this to you, but I'm saying this really for the benefit of anyone. Behaviorally based feeding therapy, which is much more, I know you could do this adult based, reward and consequence driven. And so I might get progress much faster but it's not as pleasant. And that kid, I might be chasing a moving goalpost of caloric needs for the rest of that kid's life, because now I've pushed this unpleasant experience and I got where I needed to go, but not in the best way possible. So like and then there's oral motor feeding therapy, everything else. So like, but none of these things happen in a silo. So I think to be the best therapist you can be, you really need to be well versed in all these things and also be able to adapt to what's my ask going to be, right? What's therapy going to look like? And that might be different day to day. And so I think that that's something that is much more difficult, much more challenging as a therapist, because you can't fall back on your protocol. You can't fall back on,
Right. No.
this is how it's done in this minute. And in 5 minutes, it might be done differently depending on how the kid's responding. So I think it puts a lot more of the onus on the therapist, but I think it makes you a better therapist. And I think that the emotional intelligence piece attached to families and attending to that as well, within our scope, obviously, but is also something I'm just extremely, extremely passionate about. And then I also think, and this is an area you guys are involved in as well, so you know this too, when we're talking about in the last 5-ish plus years, there's been a lot more research coming out on myofunctional therapy and on oral ties and things like that. And so with that coming out, thankfully, we have some wonderful providers that we collaborate with, and I know you do as well in this area. But I think that's another one where there can be a slippery slope of like, you find these people and you want to figure out who you can collaborate with, of who's not over recommending, who's not under recommending, who's not doing a complete oral release, who's blanketly recommending that every friend in the mouth,
frenulum is cut. Just cut
all
it all.
7,
2 or 3 times. Just cut them all off.
every time we revise them, and I'm going to cut all 7 each time. Like, what?
Every time.
So
there's no frenulum left at all.
Nothing. You have nothing tying any structures of mouth together anymore. So like, that's another thing I'm really passionate about is like, what are we, walking that line of like, what's ethical, what's not. One of my favorite providers here, who I'll give a shout out to Casey Lynn, Apollo Beach, one of my favorite providers here. Casey, he and I have known each other for years, but like, I know, first of all, he's going to recommend what's appropriate. A lot of the time he'll send these kids, thank God, if they're older especially, for pre-op care as well as post-op care, and not just clip or laser in this case, and then send him for therapy. So there is so much more team collaboration. He and my therapist text all the time. So there's so much good communication going on. And also I know that he's not just blankly recommending the same thing for every patient. So, in terms of what needs to be lasered, what doesn't. And there's several that if the parents are like, well, we're deciding, is it functionally impacting them enough that we want to go through with it, or are we trying to avoid it? That's fine too. And I've got plenty of kids that he'll be like, well, it's pretty mild. Go for therapy and let's see if therapy does enough. I love that. He's not now trying to, and sometimes it doesn't. And then we're like, hey, Casey, we've gotten where we can, or, Dr. Lynn, we've gotten where we can. Now we're ready for the next step or whatever. I also think I'm paying attention to that of like, okay, is the release complete? If it's not, are we seeing them for a follow-up in person? And, doing a revision, what does that look like? What does pre and post-op care look like? What is, are we recommending something different and individualized for those patients where it's appropriate? Are you giving them where it's appropriate? Are you giving them a shot at therapy first without just going, yeah, of course it needs to be revised, So like,
absolutely.
Because it's the same thing for me. Am I telling every kid they need the same therapy recommendations? Absolutely not.
No. Yeah. Agreed. So that's, I agree with you on that. It's something I'm passionate about. And we'll just, every kid's different, making sure we're putting them with the right people. Same thing. And good, honest people that aren't just trying to take our money, which is sometimes we do run into that. Let's just be honest. It does happen. It happens.
You always, I think, like anything in life, you have to be careful of that and trust your gut, right? You're the parent. If you're not getting
intuition. Yes.
And then, have a conversation with the therapist. I also am very big into like if the therapist is hesitant or not as forthcoming about having those conversations, those meetings with you. How many times then that should raise an eyebrow. If I'm confident in what I'm recommending, it may not be feasible for your family. That's a different conversation, and that's okay. But like, I don't ever want somebody to think it's for a money grab and for whatever. So like, I can't tell you how many conversations I've had where one parent's on board, one's not. And I'll be like, oh, we'll if it was, let's say it was dad, for example, have dad call me. Let's talk about it. So like,
this is, I like dad for an example. It's like 90%
usually dad. I hate to say that, but it's usually dad. So I think all the time, encourage questions, encourage conversations. If you're confident enough in what you're recommending, that someone asking you should not rattle you about that, So You
Right.
follow your intuition.
Absolutely.
That's, BS. No one should be pushing you into something that doesn't feel right.
Feel right. Yeah. All right. So, to wrapping up a little bit, um, what if you had to tell every parent before they had a kid, before they had a baby, even before the first 3 years, what's 3 things of advice you'd give all parents? Like, don't do this, make sure you do this.
Follow your intuition. If you think something's not right, I don't
Love
care
it.
what any mom group in the world says. If you think something's not right, seek out resources and, God willing, people that are ethical, right? Ask those mom groups for recommendations for people they've worked with personally, firsthand. Let's say it's a mom who thinks her kiddo's delayed speech. Okay. Follow your intuition. If you feel like it, God willing, you find someone that's ethical. I'm not just going to, if I'm talking to a mom of an 11-month-old, I'm not just going to go, definitely needs an evaluation for a few $100s. Again, taking into the big picture into account, sometimes maybe it's necessary depending on what the kid's gone through. But other times I might go, hey, I'm going to send you some worksheets and some suggestions on activities. Try these for a few weeks, couple weeks, call me back in a month. Let me know how it's going. And then we'll revisit, is an evaluation or therapy warranted? So I'm proactive, but I'm not an alarmist. So I think it's finding that fine balance between trusting your intuition and talking to a professional about it. So that was going to be my second piece, was just be leery of who you are taking advice from. And I don't say that in a because people don't know what they're talking about way. It's just, I think plenty of family, plenty of in-laws, plenty of friends, plenty of moms on Facebook mommy groups have a lot of opinions and advice. But at the end of the day, if this is not their specialty, this is not what their education is. And I'm not saying they don't have experience. They may have experienced something similar with their own child. But again, every case is different. So speak to a professional that hopefully is not going to be over recommending, that will be real with you and tell you when to worry and when it's not worth worrying, or what to try first. Because everyone's got opinions, right? So and they're not always correct. This whole wait and see, obviously a lot of us as therapists are very into early intervention, but there's that fine line again of I'm very high into early intervention, but I don't want people to think I'm just blanketly then recommending therapy for every kiddo. There is a time and then it's a place when it's appropriate.
Yeah.
So I would say be cognizant of who you're getting advice from, especially on Facebook mommy groups, and listen to your gut. And
Any practical advice, like as a feeding therapist,
yes,
do
my
this,
number one, I would say, is that when kiddos get to be toddlers, that's when their big push for independence is going to come in. One of the easiest ways to do that is through feeding. So you're going to start to see a lot more independence and arguing about food. They can put their heels in. Nope, seeing that, not that. I will also say some food jags, like coming off of food they used to love, or vice versa, or they ate nothing but something forever for weeks and weeks and weeks, and all of a sudden they won't touch pancakes anymore, or they never touch this and now they're having this. That's normal in toddlerhood. There is some normalcy to that. Where I look for problems when it's more like entire food groups that are eliminated, family life, quality of life getting eliminated. You can't go on a cruise, you can't go on a trip because you can't bring the only brand of peanut butter and jelly they eat. So I look at quality of life and what kind of life activities are functionally being affected. And so I would say my third piece of advice is, so listen to your gut, be leery of who you're getting advice from, and just cognizant of who you're getting advice from. And I think parents need to, there's so much mom guilt that's another one of mine. Don't take this on. I've seen it in perfect families. Okay. We've seen every dynamic of everything, and you could be the perfect parent and your kid could still have X, Y, and Z issues, whether it's with feeding, whether it's with a language delay, whether it's with sensory stuff, it doesn't matter. So really, I think the less time we can empower parents to get out of their own guilt and seek resources that instead will help them get to where they want to go, that's the most powerful thing. And then as far as functional, I went on a tangent, but I was saying, sorry, that's how
It was like 1, 2, and 3 with A, B, and C.
Sub point. I know. So I think that's how my brain works. So
Me too.
practically, I would say, expose them to a ton of stuff, even without pressure. I go on a scavenger hunt in the grocery store, right? Talk about, are things bumpy? Are they gonna be sweet? Are they gonna be sour? Is it bumpy? Is it smooth? Just make food a part of the conversation without the pressure. And I would say that especially for kids that have feeding issues already that you know about, like, I don't even want the question, at least in the beginning, do you want to try it? Like, let's just go to the grocery store and see what we can find. Let's find 5 things that are green. Let's find, go to the produce aisle. Let's find 3 things that are bumpy. Do you think if daddy took a bite out of that, it would make a loud crunch or a soft crunch? Just talk about it, and without the pressure, and let's try to build some natural curiosity. And then my biggest piece of practical advice is my number one thing, and it's because of that independence piece, is yes and no questions, and trying to avoid them at all costs, because it's the how we speak to each other in society. So it's just, and you'd be amazed, I often have parents record themselves like doing their next meal after we do an evaluation, because it's how we talk to each other to go, hey, do you think that, would you like to try it? Do you think you could take a bite? Or do you think, can you do this? Well, 99% of the time your answer is going to be no. So, because they don't want to. So then the kid is either never going to have to do it, or you're going to force it and be like, I really don't care what you just told me. I'm going to do it. We're going to do it anyway. And so to me, you're much more empowered to try and give them the illusion of some control, or give them some control, and without the pressure, and in a way that you can then gauge what's too hard, what's not, what's a big enough push. But they feel like they have a choice. Now, for example, I could say to them, do you want the blue bowl or the green bowl with your lunch today? Do you want one fork or 2? Whatever, make it up. What cup do you want? The cup with straw or no straw? And same thing. Then you eventually, when you learn that dynamic and the child feels like, okay, I have some control, right? I got to choose the blue bowl. I got to choose 2 forks today. Baller. Like whatever it is, they feel like they have control, and then you can use that to your advantage. Eventually, if it's a kid who has a feeding problem, for example, you might go from that piece of broccoli, do you want to give it a nibble or a lick, or do you want to do hide and seek in your mouth, to do you want 3 bites of broccoli to finish, or do you want 5 bites of broccoli to finish? And so then we're going up in terms of how difficult that ask is, but you're building a foundation that says this is a conversation. You have to choose one of the choices I present. So it's within the rules, it's within the parameters that I set, but I am giving you some control. So I find that can alleviate, even kiddos without true feeding disorders, feeding issues, it can alleviate some of the control battle, because the kiddo will feel like they have some say in what's about to happen to them in this mealtime.
And that's good parenting advice.
For everything. It's not just feeding.
For that age.
All choices, no yes, no questions. I don't care. Insert whatever the subject is. That's my advice.
That is really good parenting advice. It really is. I wish I would have learned it. My kids are 5 and 8 now, so I already kind of failed, but I'm learning. But yeah, so anything else you wanted to add before we got off, like your website, anything else?
Our website, we're Madden Therapy Solutions, Madden, like Steve or John, depending on if you're male or female. So that's always the question I get from guys or girls. Steve Madden, John Madden. So it's www.maddentherapysolutions.com, and our number is 727-240-6209. I'm here, even if you're not in our area and just have a question or need a resource, I'm happy to answer. And my email is admin, ADMIN, at maddentherapysolutions.com.
Awesome. Thanks so much for your time.